26%. You know, it is an
Yes, we can hear
important.
you.
Can you hear?
Yes,
And,
yes, perfect.
and you are seeing the slides also. It is important disease, you know, this rectal cancer. We have many recurrence, local recurrence. It is difficult operation, and the results all about local oxygen or sphincter saving resection or even abdominal resection are very controversial. So it is a very controversial disease. I am going to talk particularly about the distal rectal cancer, the rectal that we can reach with the finger. The finger and the eye are extremely important for rectal surgeons, particularly for rectal surgeons, but also for general surgeons or gastrointestinal surgeons. It's very important because when you you set your finger, you can see the height, the size, the deepness, the relation with the other organs, particularly important, the finger. So it is impossible. And when we talk about rectal cancer treatment, always I remember Dr. C. Alan Parks. I knew him very well. I've been in St. Mark's. He was the teacher there. And he was very enthusiastic about colloidal anastomos. And in the same year, in 1982, he published, and I published, similar papers about colloidal anastomos. I have to mention that colloidal anastomos for rectal cancer treatment was my thesis for becoming a professor of surgery of the University of Sao Paulo, Brazil. And this was the way I did it. I was always enthusiastic about colloidal anastomos. Bill Hughes, always we have to talk about Bill Hughes because he was the introducer of the mesorectal excision, a very important step on every operation, radical operation for rectal cancer. But even as being wonderful surgeons, not all cases we can cure with radical operations because for large, low, fixed distal tumors, we have even Bill Hughes, which means rectal excision. He had 70% of local recurrence, completely different from the small and higher tumors that the rate of recurrence doesn't reach 4%. So we need for low, fixed, large rectal tumor to do, besides surgeries, neoadjuvant chemoradiation. Majority of tumors are nowadays distal rectal tumors have to be treated before operation, before deciding the treatment to undergo chemoradiation, because with chemoradiation, we can decrease the size, the deepness of the tumor, and even we can decrease the number, particularly of the metastatic compromised rectal lymph nodes. We decrease the stage of the disease. And in many cases, we can even nowadays, even to 60% of cases, if we use the correct protocol of chemoradiation, we can reach more than 50%, almost 60% of complete clinical regression. It is very important. But we have to do our homage to the pioneers. We start, she was a woman, Mary Curie, and then Mayo, United States, Jukes in England, Walter Reed, and you have to say Nigro. Nigro introduced the multimodal treatment for anal canal cancer. And from Nigro, I got the idea to use non-operative treatment for this rectal cancer. I suppose if any canal cancer may be cured only by chemoradiation, why not we do the same, we can do the same, but in some cases for rectal cancer, distal rectal cancer. Also, Fallman in Switzerland, very important for conservative treatment of rectal cancer. Papillon in France, we're doing local resection, and Memphis, United States, favoring the use of chemoradiation. United States was extremely important, were men's very important men. It was a wonderful time that time. So, but this paper published by Maas in Holland and collaborators was very important because they became to the conclusion that if you achieve after neoadjuvant chemoradiation pathological complete response, oncological results were much, much better. This was very important paper in favor of neoadjuvant chemoradiation. And then, watch wait, how it started. I started doing chemoradiation, and my first first 4 cases, we had complete clinical response. And in these first 4 cases, I did the operation, and in one of them, I've done the new operation, and in the resected specimen, there was no tumor. So this is what we call complete clinical response. To mention that there is a complete clinical response, we have to do complete, not even a small lesion. We have to do disappearance of the entire lesion. We have to do this. We see no tumor, no nodules. We see these telangiectasias that there are nothing. And this is very important view of a complete clinical response. Why to do operation in this case? Impossible to do operation for this. And I resected, in some making a resection, made a resection in some patients, and we had the surprise to see no residual tumor, no cells. And why continuing doing surgery for complete clinical response? But we have to be sure that we had complete clinical response. And the most important part of our strategy that we judge the final management of the treatment of the rectal cancer after observing the response to the neoadjuvant treatment, not before, after. So after, if you have a small lesion, we can do local excision. But if there is complete response, we start doing, from my experience of operating patients without a residual lesion, I started using watch and wait protocol for complete clinical response. Biopsy, are they important? Not for all patients, because when we have a complete response, it is not necessary to do biopsy, because we know that after complete response, not always a negative biopsy means complete clinical response. So why to do biopsies? There is no sense to do biopsies. MRI, it is important diagnostic tools, and it is important to the decision of watch wait or operation. With MRI, we can see not only the mesorectal, but also the nodes. So it is a very, very important. You can see the nodes in the mesorectal. You can see the nodes, and you see here, the nodes. It is a very important, and always we have to do in all patients. PET-CT, it is a very good diagnostic tool, but we use it only for follow-up. Not, we don't use it as a diagnostic of the primary tumor. We use it when in follow-up we have doubt about some recurrence. And PET-CT for follow-up of the patients, it is a very important examination. It is an important message when we treat, because not all tumors have the same response of complete response at the same time. Some at 6 weeks, some at 8, but many of them after more than even 16 weeks. So we have to be patient with the patients, because when we have a good response, we have to wait, because you can see here, the tumor, very large one, 12 weeks, a lesion, but after 20 weeks, complete response. So we have to be patient in the assessment, interpreting with interpretation of the assessment of the patients. Surgeons, they like to do radical surgery for all patients after chemoradiation. And you see, a very good specimen, we like to resect the specimen to the rectal cancer, but we use it to do it only when we have incomplete response to chemoradiation. This is important, but we have to judge its real indications, because we know it can kill the patient, but we have a wide rate of morbidity and some degree or some rates also of mortality. And you see, we can have urinary sexual fecal dysfunction. And many patients, we need stomas, some majority temporary, but in some definite stomas. And even with radical surgery, we can have also recurrences. So we have to be very careful, very strict to indicate radical surgery after achieving a complete clinical response. And surgeons, they know that they don't like to do colostomies, but if you see the literature, we can verify that the risk of definite stoma starts at 8%, but after 10 years, it ends up even to reach 22%. So the risk of definite stomach is high. And we know that for many patients, when they accept to undergo surgery, they are most interested in having no stomach, and many, they're more interested in having no stomach much more than to the cure and no cure or no complications. Stomachs is very important. They hate to have stomachs, but we know that stomachs in many cases are really necessary. So let's go to see. Patients like this, complete response, watch and wait. Complete response, watch and wait. But here you see, it's not a complete response. It is near a complete response. And when we have a near complete response, the better for these patients is to do a full excision, local biopsy, and to have a complete pathological examination. And the patients, you see here, it was almost a complete clinical response, 7 weeks. But The patients didn't want to do their own operation, and I was patient. And you can see here, after 52 weeks, complete the appearance of the tumor. And when we are sure that we had a complete clinical response, it is a surgeon dilemma. It is acceptable to submit a patient to these complications with a great probability of not having a single cell, residual single cells? Is it ethical to do a radical operation for patients who had a complete clinical response? I don't think so. For these patients, watch and wait. We have to use herbs when we don't have complete clinical response. Then arms, radical operations. It was very difficult for me, the decision of not operating patients with complete clinical response. In our university, it was a war. Many arduous debates with all the staff. I invited Bruce Minsky from the Memorial. He came to Brazil. He saw many patients with complete clinical response. And many other colleagues from the United States, they came, they saw, but even so, it was very difficult to convince people to do watch and wait. I was, in the beginning, almost killed. They almost burned me. But I was, as a woman, I was persistent. I kept talking. I went to many congresses, many meetings. I wrote papers, and I received many written papers saying there are some some Brazilians that treat rectal cancer as hemorrhoids. They don't respect rectal cancer, but I persisted. And then this was my protocol. In the beginning, we used this conventional protocol. 2 cycles of chemotherapy, and in the first day of the chemotherapy, we start radiation therapy. Radiation, 5,000 centigrades, 3 fields. And we use always leucovory and 5-FU, very common and cheap drugs. And bolus dose as in this scheme. And you see, it took 6 weeks. And since the beginning, we waited 8 weeks because we know that radiation therapy, they have a continuous efficiency. It is not good to examine the patient soon after the end of chemoradiation. We have to wait, and nowadays, I wait more than 8 weeks. I am starting waiting no less than 12 weeks, 9 weeks, and progressively, we're changing our protocol because we got very enthusiastic with our results. Because with our first protocol, we had 27% of complete clinical response. So we made some difference, made some change. We start no more, we included another cycle during the radiation period. You see, 3 cycles during the radiation period, 3 cycles of 5-FU and then recovery. And during the resting period, that we changed into 9 weeks, we gave consolidation chemotherapy, 3 more cycles. This is called now consolidation chemotherapy. But we changed this Soon after, we had good results. And with this protocol, 6 cycles, and with little increase in the radiation therapy, we increased our rate of complete clinical response to 54%. This is the protocol, and we published it in Disease of Colorectal in 2004. Almost 6% of complete clinical response. And this is our algorithm of the protocol. Chemoradiation, no less than 8 weeks, assessment of response. If no response, immediate radical surgery. If complete response, if incomplete response, immunonodular, full excisional biopsy. Complete response, no lesion, watch and wait. And then strict, rigorous follow-up in the first year during at least every 2 months. And then during the first years, every 2 months. If you continue having complete response without signs of every time, if you had any sign of local recurrence, immediate surgery. Every time you had a recurrence, radical surgery. So we published our first paper, was accepting hands of surgery, make the comparison in patients who had complete clinical response. A group undergone operation and a group watch and wait. And you can see in this paper that there was no difference, no survival benefit of the operation over watch and wait. This paper was accepted, and then watch wait became more and more accepted. But we have to keep in mind that after watch and wait, we may have recurrence, and the rate of recurrence may reach 22% after 3 years of follow-up. So we have to keep the patients under follow-up, because if you detect an early recurrence, you can do a radical save operation and you can save the patients. And it is important the first year, because majority of local recurrence are seen during the first year of a follow-up. And this was a paper published in the literature, very important paper, and they confirmed our results. They had 23%, in Brazil we had 23%, they had 22%. It is the same. And the growth may occur, and they are related with the baseline of the tumor. The more prone are for the treated tumor at a higher rate of local recurrence. This is what we see as a local recurrence. They always have an endoluminal sign, so we can detect it very easily. And we can do, as I mentioned, save operation. In some cases, sphincter saving operations. As we had in our series, we could save, which sphincter saving operations, 93% of our patients with early detected local recurrence. We published a important paper also showing that delay operation to salvage the patients with local recursions, they have good results. And if you detect early, as you can see, delayed operation, the oncological results are not compromised. Many other papers have been published in the literature. Many multicentric paper like this one, 5 studies, they published very recently the same results as we published in 2009. And many other series, after our papers, many other series we published in the literature showing that if you correctly use watch and wait strategy, results are not different when you do radical operation after complete clinical response. And what about metastasis, systemic recurrence? We could show in our series that even using watch and wait, no, the fact of not operating these patients with complete clinical response, there is no increase in the rate of metastasis. And the literature, a wonderful paper, was recently published also in the Annals of Surgery, showing that these metastases may be saved completely even when they occur. Can we improve our results? Can we do something to improve our results? Yes, we can. And you know that we can do increasing the rate of radiation and changing the protocols of chemoradiation. We did this with the consolidation since 1999. But nowadays, many other papers have been published showing the same results. In Holland, Apple showing that increasing the rate, the dose of radiation, she could obtain higher incidence of pathological response. And in United States, Garcia Aguilar also showed that if you increase the interval for assessment the response, if you use different drugs, a combination of drugs, you can improve significantly the rate of complete pathological response. So any type of consolidation, induction, post-operative chemotherapy, if you increase the dose of chemotherapy or radiation, you have better results. This is our results in patients that have 5 years of follow-up. And you can see that in our series, with 5 years of follow-up, we had, with the first protocol, we had 29% of non-operative managed, conservative without operation. And when we change our protocol we change our protocol, now we have more, and more now, it's not published yet, but we're reaching almost 6% of non-operative managing of patients with distal rectal tumors. So this is it is important to do neoadjuvant chemoradiation to achieve complete clinical response. Consolidation chemotherapy, it is very important. And nowadays, we are employing, achieving, using sensitive therapy to decrease the resistance of the tumors to the chemotherapy. It is very important. It is also extremely important to identify the patients who will respond upfront to the neoadjuvant chemoradiation protocol. I always like to present this slide because in London, in Manchester, our good friend Fraser Smith, he has been with us 1 year here, and he's doing watch and wait. And he asked the opinion of the lawyer about the use of watch and wait, the watch and wait strategy. And the lawyer answered that nowadays, with many papers published with good results, the surgeons that don't discuss with the patients that it is possible that there is a protocol of what's when they have complete clinical response. It's not illegal, this doctor not discuss with these patients anymore. So watch rate is being much and more used in the world, as you can see here in many countries. I thank you very much for your kindness in listening my experience. And remember, Arthur Schopenhauer, that all truths pass by three stages that you can read here. And I passed for these three stages. And now, watch and wait is becoming more and more self-evident. Thank you very much.
Thank you, Dr. Angelita. Amazing presentation. We can start by taking questions if you have time.
Questions? Yes, I'm fine.
Dr. Okay, Dr. Ahmed
Hisham,
Mustafa, you can please raise your hand if you have questions. Yes, it's
thank you, Professor Angelita. Actually, your work is very inspiring to many surgeons, and many patients all knew their sphincters. My question is, what makes this tumor respond and the same tumor with the same stage and the same pathology doesn't respond? So we know the results, but why? Why this tumor respond and the other one doesn't respond? Did you study anything related to this point?
We have a group that studies cancer, Ludwig Institute. We're trying to find studying these cells, but we are doing some study about this because we are very much concerned about this, but we don't have any final yet. We don't have results. Soon.
Is it related to the genetics? Maybe the genetics of...
Yes, we have a very group studying genetics of these cancers, but not yet.
Answer it. Okay.
We are almost reaching.
Okay, thank you.
Any more questions? Please raise your hand. Dr. Gamal? Dr. Gamal Amira, please go ahead.
Yes. Do you hear me?
Yes, we can hear you. Please go ahead.
Yes.
Thank you for this excellent lecture. I have attended one of your lectures before in United States, and I think at that time you didn't mention the PET-CT. You discussed the MRI, the PR, and the colonoscope. Have you added the PET-CT recently, or it was from the start?
Can you repeat, please? Asking him to repeat.
PET-CT and MRI, you know, we use more and more MRI. We use PET-CT in the follow-up, not to assess the response. Nowadays, I think it is very important, PET-CT, for follow-up, because we can judge the patient, study if they have metastasis, systemic metastasis also, besides the local metastasis, local recurrence, we study also the metastasis. So PET-CT, it is not easy here. It is expensive, and we keep it for follow-up.
Another question. Do you have cases that respond locally in the rectum but not in the mesorectum. I mean, still there are nodes in the mesorectum?
Yes, I have, and I do operation in these patients because there are some patients that the tumor disappears. There is no tumor in the rectum, but there are some nodules, and I do the operation. And you know, I have two patients, and one of them, in the specimen, there was no tumor in the lymph nodes. It is difficult, the judgment. And more recently, I had another one, and I am keeping this patient under a strict follow-up because I am not convinced, totally convinced, that the presence of lymph nodes in the mesorectal without a tumor in the rectum, it is important. I am following the last patient. The two others, I did the operation. In one, I found the tumor, in another, I didn't find it. And now I am not certain, but perhaps we can follow these patients without immediate radical operation.
Do you take a biopsy for such patients who has doubtful nodes in the mesorectum? Do you take fine needle?
If possible, I take it, but it is not easy to biopsy these nodules. It is not easy.
Thank you.
Not easy.
Thanks very much.
Thank you, Dr. Medhat Khafaga, please go ahead.
Thank you, Dr. Habr-Gama, for this very good lecture, because we used to try to find the response after 6 weeks or 8 weeks, but you extended to about 5 months. And so we learned a lot, and we learned that we have to do consolidation chemotherapy for 3 cycles after finishing of radiation therapy, which increase the response rate. This is we don't know that. My question is that the problem is to find responders from non-responders, right? Did you try to use circulating tumor DNA in the blood to know if there is complete response or not? Or you didn't try that? Circulating tumor DNA, liquid biopsy. Did you try to do it?
I am not doing liquid biopsy, but there are some papers published with this. Perhaps it will help. It is a good, we are not doing it yet.
Okay, we will try to do it. But we didn't find any literature so far.
So far.
There is some, I thought you have done that. Thank you.
Dr. Fauzi, you have a question? Fauzi Abu Hijla.
Yes, thank you. At the beginning, I would like to thank the professor for her very informative lecture, and also my Egyptian colleagues and Dr. Sami for giving me this opportunity to attend with you guys. I'm a radiation oncologist from Jordan. My question, I have 2 questions actually. The first one, dear professor, have you noticed any difference in the pattern of recurrence for the patients who underwent the new protocol from the patients with the conventional one? So with intensified chemo and with higher radiation dose, were there any difference in the pattern of recurrence in the pelvis? This is my first question. My second question is, have you practiced surgery in total neoadjuvant settings with short course radiation? And if you had, was there any difference from the conventional long course chemoradiation? Thank you.
No, I don't have experience on the short course, and I have no experience on that. Do you have experience on this?
So we have shifted since the publication of the recent Rapido and Polish trials. We are doing more total neoadjuvant in the settings of short course. We have shifted since 6 months in our center, yes.
We don't do short, we don't do total. We are doing our convention, our consolidation protocol until now.
Okay.
Perhaps
So regarding
we are thinking in use some more new drugs to the large infiltrative low rectal tumor since the beginning. Perhaps it will be another protocol.
Mhm. And regarding the pattern of recurrence, have you noted a different pattern of recurrence, let's say less central tumor, less mesorectal recurrences, more in the pelvic, with the higher radiation and chemo dose, or you haven't witnessed any difference in the pattern of recurrence?
No, I didn't even notice no relation between the pattern of the tumor and the response. Some very advanced cancer may respond better than small ones.
Mm-hmm.
Where there is something in the cellular metabolism, in the cellular genes that may be more important than the size and penetrance, infiltration of the tumor.
Okay, thank you.
Thank you.
Dr. Sami Ramzi? Dr. Sami Ramzi, do you have a question?
Yes, thank you, Professor, for your presentation. Well, my question regarding the causes of failure of complete response. Did you study these causes?
The causes of complete response?
Of failure of complete response. What are the causes of not achieving complete response with neoadjuvant chemoradiation?
I don't know. I have to study the genes, genetics, because until now I don't know. I don't know. I don't know.
Okay.
We don't survive. When we have a tumor, we never know which will be the response. Until now, I don't know.
Okay, thank you.
I think, oh, this tumor will disappear, and they will not.
Thank you very much.
Dr. Gamal, any
Yes,
more
I have.
questions?
Yes, please. Do you hear me? Yes?
Yeah,
yes, we can hear you.
Yes. Do you think this can be applied also for the upper rectum and sigmoid and descending colon? The same principle can be applied?
No, I think that it is difficult to do radiation sigmoid because of the small bowel. It will be very difficult. The small bowel goes inside the pelvis. It's difficult.
Yes, but for the upper rectum, it can be applied also for the whole rectum, or no? Only lower rectum or the upper also?
I only do for now. Sometimes the medial rectum. Sometimes when it is infiltrated, middle rectal cancer, I use it. But my preference is for distal rectal cancer.
Thanks.
Dr. Ahmed Mustafa, you have one more question? Any more questions, please?
Yes, please. Hisham, okay. Professor
yes,
Angelita, do you have cases with systemic relapse and no local recurrence? And in these cases, and in these cases, do you treat the primary or only the secondary?
No. After you do the singles or metasynchronous? Synchronous, I resect
yes. Synchronous if the rectum is CR, complete remission of the rectum, but you have a liver metastasis. Do you go for the liver only, or you treat the primary in this situation, even if there is no tumor?
No.
So
I do not. If there is no tumor in the rectum, I watch and wait in the rectum. But I treat surgically the metastasis if they are surgically resectable.
Yes, okay, it's clear.
Whenever
Thank
they are
you.
resectable, I resect.
And is this a common scenario to have a complete response in the primary and metastasis? Is this a common scenario, or this is not common?
Not common, but I have kids, but it's not common.
Okay, thank you. Thank you.
Any more questions? Any more questions from the younger audience? Dr. Heba, I see you raised your hand. Please, Dr. Habr-Gama.
I would like to ask about after how long from the watch and wait policy you consider the patient cured? I mean, the follow-up period is how long after the watch and wait policy? And my second question, the extension of the timing from the initial response of the tumor to the neoadjuvant chemotherapy to surgery. How long should we wait at maximum? I mean, when to say that the patient will not achieve a complete clinical response and do the surgery for him or her.
I had a patient, present a patient with 52 months. You know, when I examine the patient and I observe that there is a continuous remission, more and more disappearance of the tumor is decreasing in size and in depthness, I follow the patient. But in the subsequent examination, if I do not see regression of the recurrence, I do radical operation.
And do you need endoscopy each time or just digital rectal exam for the patient?
No, I do rectal examination when there is nothing, and I do MRI whenever I need it. But MRI, no less interval than 6 months.
So do you recommend that we do, we wait for 6 months from the last session of chemoradiotherapy to decide whether the patient achieved a complete response or not?
6 months, it is not good. Now more than 8. And I am
8
not,
months?
I am more, if I wait 8. Sometimes the patients, they go to my office because they like to go to the office at 6 weeks. But it is not enough. When I see the tumor, it is decreasing, but the tumor is there. I wait, I call the patient, come again, come. The patients come to my office very often. If we intend to do the watchman strategy, we have to keep good contact, good empathy with the patients, and they have to go to your office very often for many longer time. And even I don't.
So
for more than 5 years, for more. I have a patient. My first patient was in 1921. And you can imagine that some of these patients, they still go to my office to say, hello, I am well, I am fine. But I keep a very good. These are my selected patients.
Very good option for a patient not to do surgery, but the question is, before telling. But how
cannot hear you, Dr. Heba,
before telling the patient that he will not achieve a complete response? This is what I mean. And should.
When I do not achieve a complete response, I talk to the patient. Now, unfortunately, you have to undergo an operation. And they will agree because they were well informed since the beginning that they should undergo an operation if they did have complete clinical response, or even if they got complete response and the tumor recurred in the future. They knew since the beginning that it was no non-operative treatment. It was a non-immediate operative treatment, not immediate. It is a delayed. Yes. It may be forever or maybe postponements.
Okay, thank you.
And you know, the
Dr.
patients,
Medhat.
when they go to my office, they go with the hope, not that they're
To
going to
unmute.
operate. They keep saying, oh, don't be so lucky because this tumor may recur. Don't be so happy. Don't be so happy because the tumor may recur. You have to come back here.
Well, I have two questions for you. First question, did you try SCBRT, stereotactic body radiotherapy, in giving radiotherapy in 5 to 7 treatments? And also, what is the impact of chemoradiation on the sexual function as regards the impotence in such cases?
Yes, you made a good question. Many of them, they may have, and I have to advise also them that radiation may compromise the sexual function. But then we have to talk to this because not all of them, but some of them. And it is very important to have a very good radiotherapist and to be always in touch. We have to have a group. The oncologist, the radiotherapist, and the surgeon. It must be a group of friends working together.
How about the stereotactic body radiation therapy and giving concentrated doses in 5 to 7 treatment only? Did you try it? You know stereotactic body radiotherapy?
Sorry, I didn't understand.
No, oh, okay. This is a way to concentrate the radiotherapy, and they give about 700 or 600 centigrade.
I never no more than I didn't use that. I know there are very good paper from Europe. They use from Holland. They use more than 60, but I never use it. The more I use, it is 54.
Okay.
Any more questions? Okay, I guess that was it. We would all like to thank you, Dr. Angelita, and we're very proud to have you and maybe see you in Egypt one day. Hopefully see you here.
Thank you very much. I hope to see you again very soon. We hope everything will finish and you'll be able to travel and you can be able to come to the Fikari. And we can
hopefully, yes, we hope.
Next year we are going to have Fikari again.
Our meeting.
Our meeting, our tradition, waiting for you. We'll let you know.
Yes, hopefully. Thank you. Yes, I will email you and thank you for joining us today.
Thank you.
Bye bye.
Stop.